السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Good evening, ladies and gentlemen. It's my pleasure to lead this session. My name is Abdul Halim Kinsara from the National Guard Hospital. The session of today is a very important session that is really we are facing in daily practice. There is a lot of committees, a lot of IBB, a lot of memos of understanding to control this test. But unfortunately, till now, we did not reach to what we really expect from us. Having the basic science of it and having the clinical science of it is really a very essential. The WHO has been classified an ST elevation MI. They requested 2 corners, at least, out of the 3, symptoms, ECG features, and the markers. But what happened now, in many instances, we forget the clinical symptoms and just we go with the marker. When we use the markers, we just keep using it without really affecting the patient management. And we move from the cardiac enzyme to the cardiac markers with the understanding that we will improve our patient care, we'll get a more focus on the investigation, that is will give us a more yield. But unfortunately, on the other side, we end up with a syndrome of troponitis. And that is, again, a challenge for the health administrator because it's really cost a lot. And not the test by itself, but the consequence of this test, the subsequent investigation, the unnecessary consultation, and the unnecessary other investigation going to the cardiac CT, stress testing, and so on. So I think really to have a people expert in this field who really can teach us how to approach this is really, I think, is very essential. I'm really glad with this activity that has been led actually by the group of the biochemistry, which الجمعية السعودية للكيمياء السريرية. I think I really glad to congratulate them for taking this concept and congratulate them for choosing the speakers as well. It's really my honor and pleasure to introduce our first speaker, Dr. Salam Saadeddin. She is really a clinical scientist, so that is give us really a great insight of the test of today. And she have really a big experience with Prince Sultan Cardiac Center, which is a very busy center. And she has been involved actively with us, with the Saudi Prevention Group as well. So I think really she will tell us from the basic of how the cardiac troponin, what is the basic principle of it. So Dr. Salam, the floor is yours.
Thank you, Dr. Kinsara, for the introduction. Thank you, Dr. Kinsara, for the introduction. I would like also to thank the Saudi Society for Clinical Chemistry for arranging this scientific event, and also many thanks for Snibe company for sponsoring this event. And I would like to welcome all the audience with us today. I will share the screen.
Yes, we can see the screen now. Great. Full view.
You can see it now?
We can see it, but just please choose the full view of the slide. Great, that's it.
Yeah.
Thank you.
Okay. Okay. My topic today, Assalamu alaikum. My topic today is cardiac troponin, the basic principles. Bismillah ar-Rahman ar-Rahim, wa salatu wa salam ala Sayyid al-Mursaleen. I will start with the very basic, the myocardial cell. Each myocardial cell contains numerous myofibrils, which are long chains of individual sarcomeres, the fundamental contractile unit of the cell. Each sarcomere, as we see here, is made up is made up of two groups of overlapping myosin and actin thick myosin and thin actin filaments of the contractile proteins. Biochemical and biophysical interactions occurring between these myofilaments produce muscle contraction. Now, troponins. What are troponins? So many people think that troponins are enzymes. They are not enzymes. Troponins are structural proteins involved in the regulation of cardiac and skeletal muscle contraction. These are the troponins. The troponin complex is composed of three subunits. Cardiac troponin C, which binds calcium ions that regulate the contractile process. Triponin I, which inhibits the ATPase activity of the actin-myosin interaction. And Triponin T, which attaches the troponin complex to the actin and tropomyosin molecule. Now, how does the myocardial cell contraction occur? On stimulation, calcium ions are released in the cytoplasm. Calcium interacts with cardiac troponin C, which inhibits the binding of cardiac troponin I, and that will lead to conformational change in the tropomyosin, as we see in this picture. That will lead to that cardiac troponin I now is no longer interferes with the binding of the myosin and actin. Myosin heads activation, these are the heads, and ATPE hydrolysis occur. Myosin heads bind to the actin filaments and flex, and this is how the contraction occurs. Now, troponin location within the myocardial cell, the myofibril troponin predominantly bound to the contractile apparatus, while the cytosolic troponins contain only 6 to 8% of total troponin T and 3 to 4% of total troponin I. Cardiac troponin isoforms and their use in the diagnosis of myocardial injury. Cardiac troponin C has one isoform that comes from a specific gene. It is expressed in both cardiac and skeletal muscles, and both cardiac and skeletal cardiac troponin C are identical. Therefore, it cannot be used in the diagnosis of acute myocardial injury. Cardiac troponin T, we have 4 isoforms that comes from a specific gene, and they are expressed in cardiac muscles, developing fetal skeletal muscles, and regenerating adult skeletal muscles. The skeletal muscle troponin T isoforms are not detected by the new generation of cardiac troponin T assays. And the cardiac troponin, the cardiac isoforms of the cardiac troponin T have unique amino terminal sequences that are not found in skeletal muscle troponin isoforms. Therefore, it can be used in the diagnosis of myocardial injury. Cardiac troponin I has 2 isoforms that come from a specific genes, and they are only expressed in the cardiac muscles, and they are absent in the skeletal muscles. Therefore, we can use it for the diagnosis of acute myocardial injury. The role of cardiac troponins in the diagnosis of myocardial infarction or injury is well established. Death from cardiovascular disease, as we see from this figure, it is 48% due to acute coronary syndrome. And this was published by WHO in 2017. So the diagnosis of acute coronary syndrome is made in conjunction with clinical assessment. Patient assessment, like chest pain characteristics, plus clinical assessment, ECG, echo, etc., and plus laboratory assessment, which is the delta change of the troponin. Myocardial infarction, how does it occur? Block in the artery, coronary arteries, will lead to muscle damage, and that will lead to increase in the markers of cardiac injury. Now, what is the history of cardiac injury markers? In 1955, SGOT was introduced, and in 1960, LDH, which had a little bit better performance, was introduced, and in 1967, total CK was introduced. All three of them are non-cardio-specific. In 1972, CKMB activity was introduced, and in 1986, CKMB mass was introduced, but it wasn't widely used because it is costly, because it needs an immunoassay analyzer to be run on it. In 1989, cardiac troponin T assay was introduced, and in 1992, cardiac troponin I was introduced. In 2006, first fully automated troponin assay approved by the FDA, by Bayer company, was introduced, and this is a conventional immunoassay. New definition of acute myocardial infarction. The National Academy of Clinical Biochemistry, the European Society of Cardiology, and the American College of Cardiology recommended that the cardiac troponin cutoff values for diagnosis of myocardial injury be the 99th percentile of the normal reference population at a level measured with a coefficient of variation less than or equal to 10%. Now I will start talking about the conventional assays, conventional troponin assays. I will take cardiac troponin T as an example. So the diagnostic level for MI in microgram per liter is 0.1. The lower detection limit is 0.01. And the cutoff value of the 99th percentile measured with CV less than 10%, which is called the upper reference limit, is 0.014. Now, the release kinetics of cardiac troponin in myocardial infarction, we see that troponin peaks at 24 to 48 hours after onset of disease, and there will be later a slow clearance that permits late presentation diagnosis. And if this is the 99th percentile, we can see that in the conventional assays, the lower detection limit is very close to the upper reference limit of healthy population. The cardiac troponin is first detected at 6 hours after onset of disease using the conventional assays. Now, diagnosis of acute myocardial injury is made by the detection of 20% rise or fall of cardiac troponin measured at 6 to 12 hours interval using the conventional assays. Now, the evaluation of a patient with possible acute coronary syndrome. First, the coronary pathology. The coronary might have mild to moderate occlusion, as we see here, or partial occlusion with platelet aggregation, or partial occlusion with thrombus, or total occlusion with thrombus, as we see from these pictures. Now, how does the patient present with a chest pain? In the mild moderate occlusion, chest pain occurs only with exertion, while in the other three, it occurs at rest. What about the ECG? The ECG in the mild moderate occlusion looks normal, while for the partial occlusion with platelets and the partial occlusion with thrombus, we have ST depression. For the total occlusion with thrombus, we have ST elevation. What about troponin using the conventional assays? For the mild moderate occlusion and the partial occlusion with platelet will still look normal. For the partial occlusion with thrombus, it will be increased. And for the total occlusion with thrombus, it will be highly increased. Now, what is the diagnosis? The diagnosis for the mild moderate occlusion is called stable angina. For the partial occlusion with platelets, it's called unstable angina. For the partial occlusion with thrombus, it is called non-ST elevation myocardial infarction or non-STEMI. And for the total occlusion with thrombus, it's called ST elevation myocardial infarction or STEMI. All three of these are called acute coronary syndrome. Now, for the conventional cardiac troponin immunoassay, there is only one commercially available cardiac troponin T assay by Roche Company and 12 available cardiac troponin I assays, or more than that now. The currently available cardiac troponin I assays produce differing results. Standardization of cardiac troponin assays is extremely important to allow for appropriate interpretation of troponin values across different medical systems. Now, the cardiac troponin immunoassays use monoclonal antibodies that recognize epitopes at amino acid residues in different parts of the molecules. Now, for cardiac troponin T, the fourth generation of cardiac troponin T assay uses monoclonal antibodies that recognize epitope 5 residues apart in the central part of the molecule. What are the factors that influence cardiac troponin I measurements? Cardiac troponin I measurement is influenced by multiple factors, complexing with other molecules like heterophil or human anti-mouse antibodies, cardiac troponin C, heparin, phosphorylation of serine and 22 and 23 residue, and proteolytic degradation. Cardiac troponin I is highly susceptible for proteolytic degradation. However, the central part of the cardiac troponin I is closely interact with cardiac troponin C and the troponin complex, and cardiac troponin C protects the cardiac troponin I from proteolytic degradation. Therefore, it is important that cardiac troponin I assays uses antibodies specific to epitopes in the central part of the troponin molecule that are not affected by the above modifications. Benefits of rapid diagnosis of acute coronary syndrome, or MI. There is more rapid delivery of appropriate medication and therapy. There is a decreased risk of delayed reperfusion in unrecognized MI. Reduced overcrowding in the emergency department and a free capacity for patient in need. There is faster discharge from the ED and reduced patient anxiety, reduced resource use. Now, I already spoken about the conventional assay. Now we will talk about the development of high sensitivity assay. Because now we have more sensitive antibodies and better detection probes on the tag antibodies and buffer optimization, that led to improvement in the analytical performance of cardiac troponin assays. And now we have superior sensitivity and precision. Important issues and key concepts relating to high sensitivity troponins. There is a need for a universally accepted nomenclature. Several names have been used in literature for these assays, including high performance, highly sensitive, high sensitive, ultra sensitive, novel highly sensitive, sensitive, and high sensitivity. And the proposed term is high sensitivity cardiac troponin. Now, high sensitivity cardiac troponin T, first cardiac troponin T, high sensitivity cardiac troponin was in 2009 that got the CE mark, and it was by Roche. And in 2013, high sensitivity cardiac troponin I assay got the CE mark, and it is from Abbott. In 2016, Snibe had the CE mark for cardiac troponin I. In 2017, Roche Generation 5 high sensitivity cardiac troponin T got the FDA approval. And in 2018, Siemens high sensitivity cardiac troponin I and Beckman high sensitivity cardiac troponin I got the CE and the FDA approval, and the AT Healthcare high sensitivity cardiac troponin I got the FDA approval. In 2019, Ortho high sensitivity cardiac troponin I got the CE approval, and Abbott high sensitivity cardiac troponin I got the FDA approval. Now, if we see the same figure using the high sensitivity troponin, we find that it is the lower detection limit is much lower than the upper reference limit, and it is first detected after 2 to 3 hours using the high sensitivity troponin compared to the conventional, which is after 6 hours. So now, again, with our example, the lower detection limit here, it went down from 0.01 to 0.003 using the high sensitivity assay. A high sensitivity assay permits measurements of concentrations that are 10 times lower than those measurable by conventional assays. Therefore, it refers to the analytical characteristics of the assay and does not mean that a different form of troponin is being measured. For an assay to be a high sensitivity assay, it must meet the following criteria. First, the total imprecision of the assay at the 99th percentile of the reference population should be less than 10%. 2, the assay should detect at least 50% of healthy individuals comprising a normal reference population above the limit. And the results from the assay can be reported in nanograms per liter. So if we change these values from microgram per liter to nanogram per liter, they will look like this: 3, 14, and 100, which are much easier to interpret. Now, if we check the timing of conversion to positive troponin I in patients with myocardial infarction, if this is the conventional non-high sensitivity assay, and this is the high sensitivity assay, we can find out at 24 hours, for both assays, high sensitivity and conventional, all patients are positive for MI. While at presentation, using the conventional assay, all were negative, and 61% of them are positive for a high sensitivity cardiac troponin assays. So we have more and early detection of true cases of MI. So high sensitivity assays can improve the detection of myocardial injury, more detection at earlier time, and can help identify risk of cardiovascular diseases, reduction of adverse outcomes. Now, the diagnosis of acute myocardial injury, 3 hours protocol, which was published in the European Heart Journal in 2015. They used these 3 values: 3, which is the lower detection limit, 14, which is the upper reference limit, and 52, the hour reference limit, times 3. So if the first reading is less than 3, diagnosis of MI is very unlikely. If the first reading is between 3 and 14, it is common to detect circulating levels of cardiac troponin in healthy individuals between these levels. Therefore, second reading after 3 hours is needed, and if it is lower than the upper reference limit, which is 14, it's not MI. If it is higher than the upper reference limit, a third reading after 3 hours is needed. If it is less than 50% rise, it's not MI, due to MI, and if it is more than 50% rise, it is due to MI. Now, if the first reading between 14 and 52, the positive predictive value only 50 to 60%. So there is a need for a second reading at 3 hours later. And if it is less than 50% rise, it's not due to MI. If it is more than 50% rise, it is due to MI. Now, if the first reading is more than 52, we need a second reading 3 hours later. And if it is less than 20% rise, it's not due to MI. If it is more than 20% rise, it is due to MI. Now, if the first reading is the upper reference limit times 5, which is 70, this is highly abnormal high sensitivity troponin, and the positive predictive value is more than 90%, and diagnosis of MI is likely. The distribution of high sensitivity cardiac troponin T in patients with stable coronary artery disease and in apparently healthy donors representing low risk population. This was published by New England Journal of Medicine in 2009. And if this, in the x-axis, the high sensitivity cardiac troponin, and on the y-axis, relative frequency, they found out that cardiac troponin T more than 0.001 microgram per liter was in 97.7% of the studied population. And cardiac troponin T more than 0.013 microgram per liter was in 11.1% of the patients with stable coronary heart disease and healthy blood donors. This raised the possibility that some troponins may circulate under normal circumstances in human plasma. Recent studies demonstrated that age and gender affects cardiac troponin value, and this was published in 2014 by the Journal of American College of Cardiology. Age, especially older than 60 years, affect high sensitivity cardiac troponin values. More than 10% of men older than 65 years of age who are free from clinical or subclinical cardiovascular disease have high sensitivity cardiac troponin values above the current MI threshold. Also, gender affects high sensitivity cardiac troponin values, with men having higher values than women. Example, high sensitivity cardiac troponin cutoff point is in true normal is higher in men, which is 21.5 nanogram per liter, than in women, which is 13.8 nanogram per liter. This can result in overdiagnosis of MI, particularly in elderly men. A more recent systematic review done by Clinical Chemistry Journal in 2018, they said 6 specific versus overall clinical decision limits for cardiac troponin I and T for the diagnosis of acute myocardial infarction. A systemic review, they confirmed that the 99th percentile are much lower in women than in men. And if you see here, the high sensitivity cardiac troponin T using Roche Lexus, the difference between men and women is 6.5, and the difference for high sensitivity cardiac troponin I by Abbott Architect is 18.6. Now, 99th percentile upper reference limit for multiple high sensitivity cardiac troponin I assay demonstrate much lower values in women, which are in red color, than men in blue color, except for the Beckman assay. Also, the 99th percentile upper reference limit for multiple high sensitivity cardiac troponin T assays demonstrate much lower values in women, as we see here, than men. New and updated 2020 IFCC CCB, which is the Committee on Clinical Application of Cardiac Biomarkers, and the AACC, the American Association of Clinical Chemistry Academy, laboratory, they said that laboratory are as follows. First, QC materials need to be implemented at concentrations consistent with both the male and female 6 specific upper reference limits. QC materials should be considered at concentrations consistent with the limit of detection of each high sensitivity cardiac troponin I and T assay to provide ongoing confidence when used for rule-out protocols. Avoid implementing upper reference limits that use underpowered subject numbers to establish the 99th percentiles. High sensitivity assays are now defined based on measuring more than 50 or equal to 50% of normal males and more or equal to 50% normal females individually, not combined. Whole numbers in nanogram per liter are only designated for high sensitivity assays. Beware of conventional assays that report results using whole numbers. This new update was published in Clinical Chemistry in 2021. Now, the role of point-of-care testing in the era of laboratory for high-sensitivity cardiac troponin. Currently, the majority of point-of-care testing for cardiac troponin assays have at best performed as conventional assays, not high sensitivity. Adequate for ruling in myocardial injury, but require repeat sampling post-admission to achieve adequate clinical sensitivity for rule out. These high sensitivity assay, obvious advantage of the point of care testing, namely the shorter turnaround time, is counterbalanced by lower sensitivity, lower diagnostic accuracy, and lower negative predictive value. Overall, automated central laboratory-based high-sensitivity cardiac troponin assay have been more thoroughly evaluated than the point-of-care testing ones and seem to be preferable at this point of time. This was published in 2021. The majority of POCT assay studies claiming comparability to high-sensitivity cardiac troponin assay for diagnostic clinical utility and adverse outcome have not been performed appropriately. They utilize stored plasma samples, not fresh whole blood, which is required for a universally acceptable validation. PathFast assay has FDA clearance for point of care with preliminary data that meets high sensitivity criteria along IFCC guidelines. However, in practice, users of this large instrument are often laboratory staff and not designated point-of-care operators. Several novel in development point-of-care technologies will hopefully provide diagnostic data to be utilized in practice soon. The use of high-sensitivity assays will lead to increase in the number of patients who present with conditions other than acute coronary syndrome and detectable cardiac troponin, as we have seen from all this lecture. An important issue during the clinical utilization of high-sensitivity troponin, which will be elaborated more in the next lecture by Dr. Habab. Thank you.
Thank you very much, Dr. Salam. It was really elegant presentation. You took us across the journey very nicely, and we really learned a lot from this and created really a more clear concept about the troponin and the high-sensitive troponin. Now it's my pleasure to introduce the speaker who is really a father of the cardiology in this country, I think. Dr. Muhammad Habab, he's a consultant cardiologist and electrophysiologist. He's really being the head of a cardiology department in the Prince Sultan Cardiac Center. He's well known to the community. He's director of training and academic affairs as well. He is also what we call it a pillars in the Saudi Council accreditation program in the cardiology, and has been a lot of contribution in the scientific content of the cardiology fellowship. And you will not find a better person than him to tell you about the clinical aspect of the troponin, where he combined his great knowledge with the great clinical experience that he had. So Dr. Muhammad, the floor is yours. Just before Dr. Muhammad is start, I'd like really to encourage you strongly to send your question through the chat, because I'm sure you will have a lot of questions, and I'd like really to learn from our experienced speaker. And also I'd like to point out that this activity is accredited by the Saudi Council for 2 hours. No certificate will be issued. At the end of the session, you will receive an email, like a small survey, and in that survey, you need to put your Saudi Council number. Once you put the Saudi Council number, then your CME hour will be generated for your account. Dr. Muhammad, welcome, and the floor is yours.
Thank you very much, Dr. Abdul-Halim. Very nice words. Thanks a lot. I would also like to thank again the Saudi Society for Clinical Chemistry for this scientific activity and their sponsor, Snibe. And a special welcome to the 2,532 attendees so far who are joining the session, and hopefully they will get the benefit that they are looking for the subject of troponin. So, Bismillah ar-Rahman ar-Rahim. My talk will be, as mentioned, is to cover the second part of the talk, the clinical utilization of cardiac troponins. The conventional versus sensitive cardiac troponin assays were nicely demonstrated in the first lecture. Now, I just like to highlight a few points. If we look at the pathological changes in the x-axis and the level of cardiac troponins in the y-axis, we'll find a normal subject, the cardiac troponin T-turn. Over here, it goes up and down, waxes and wanes in normal tissue. Now, when we have an MI, myocardial infarction, from the onset of it, the troponins start to leak and increase in the serum and in the level. And during ischemia and micronecrosis, they will be slightly elevated there. But when necrosis really kicks in hard, around 3 to 4 hours, then we will have very high levels until we reach the peak that Dr. Salam Saaduddin showed you in the first lecture. Now, after that, there will be post-operative event and the kinetics will continue. But this is the area we are focusing on when we talk about the high sensitivity cardiac troponin mainly. Now, the conventional generation of cardiac troponin assays used to measure in this area here after necrosis kicked in and some of the damage already occurred. That's why they look for sensitive generation cardiac troponin to separate ischemia from necrosis there, or micronecrosis from really massive necrosis. But the high sensitivity cardiac troponins can measure down up to the normal level or just the beginning of the rise, which makes them very, very important in this situation. Now, the conventional, if we look at the conventional versus high sensitivity, again, from different perspective, the conventional assays measure the troponin in micrograms per liter. I'll use troponin T as an example also. They have a limit of detection, and we have the CV of 10%, which is proposed by all organizations. Now, anything above that is pathological. Anything below this is not detectable because it's lower limit of detection. In between, there will be likely pathological in the situation for the conventional. Now, the 99th percentile or the upper reference limit, we don't know what it is and how much in this situation because it's lower than the limit of detection usually. And that's why we call these values in this area likely normal. Now, the high sensitivity assays measure troponin in nanograms per liter, meaning 1,000 times less than that, and the value will be more, of course. Their limit of detection is far low. That's why the 99th percentile can be identified, and anything below that is normal, except below the limit of detection, and anything above that is pathological. Now, for the high values of troponin, both conventional and high sensitivity assays are really the same. Here it is 0.1 microgram per liter. This is 100 nanogram per liter, exactly the same in high level. That's why we don't depend on troponin when we have clear, obvious high troponin, like ST elevation MI with chest pain and the guy is screaming. We don't wait for that to or get it except for prognosis, as we will talk about it later. But the main area to focus on, and these molecules are going to be very helpful, is to catch the patient before he reaches this very high level. It is in the lower area there. And Dr. Saaduddin showed you that this area here can include the normal as well as other pathology like early stage of acute coronary syndrome, acute myocardial injury, chronic myocardial injury, and normal people. These The art now is to separate between them, and the universal definition of myocardial infarction kicks in and makes things handy for this purpose. Before that, we go to the mechanism of cardiomyocyte injury and associated disease state. If these are normal cardiomyocytes, what do we have? We have cardiomyocyte necrosis due to myocardial infarction, where the cell dies and the contents released in the circulation. We have inflammation, like in myocarditis, myopericarditis, sepsis, and heart failure, where inflammation affects the cell, breaks the wall, and the contents of the cytoplasm leak. And we have apoptosis, the programmed death, and heart failure, hypertensive urgency, and increased left ventricular systolic pressure, where the cells die and release their content. Cell turnover, physiological cell turnover in physiological conditions, as well as exocytosis, which is physiological cell turnover, ischemia, and heart failure. And I will elaborate on these microblips later on. Keep this picture in your mind. This is the microblip formation in this situation. So the fourth universal definition of myocardial infarction states that elevated troponin values more than the 99th percentile upper reference limit is called myocardial injury with necrosis. And it can come with rise and fall. When it comes with rise and fall, we call it myocardial injury. And when it is stable and increase, this is not rise and fall, but it is waxing and waning. And this rise and fall can occur in two conditions. One with symptoms, signs and symptoms of acute ischemia, and another situation without signs and symptoms of acute ischemia. Now, the stable systemic condition will give us waxing and waning, small elevations, less than 20% rise and fall, and we'll cover them in a minute. The acute ischemia can be due to acute coronary syndrome, which is the coronary atherothrombosis. That is type 1 according to the universal definition of infarction, caused by atherothrombotic coronary disease, and usually precipitated by atherosclerotic plaque disruption, rupture, or erosion, and it includes STEMI and non-STEMI. The non-acute coronary syndrome, but with acute ischemia and symptoms, can be due to oxygen supply and demand imbalance. And this is type 2 in the definition of the universal definition of myocardial infarction. And it is defined as ischemic myocardial injury in the context of mismatch between oxygen supply and demand, and not due to acute coronary syndromes. If it's not, it's due to what? Now, this supply-demand mismatch can be due to decreased oxygen supply, like an anemia, hypertension, and others, or increased demand, like tachycardia, LVH, or increased left ventricular size or pressure. Both will lead to reversible subendocardiac ischemia or irreversible myocardial ischemia. Now, the reversible one is really mediated by microblip formation, while the irreversible by cell necrosis and cell death. What's microblip? If we look at the myofibril under the electron microscope, this is the normal myofibril that keeps the heart pumping all through life. And it has sometimes small blips that come out, which is normal. And that causes the minus small troponin in the circulation that we see usually. But if we expose this filament into 30 minutes of anoxia, look at these microblips, what happens to it. The membrane starts to generate the skeleton here. The cytoplasmic content bulge up within that membrane, and they form microblips. When these are washed into the circulation, they carry with them the troponin, and that's why the troponin start to rise small in a small amount. Mind you, this is the cytoplasmic troponin now that plays a role, not the structural one, as Dr. Saadeddin showed you at the beginning of her lecture, that these account for 6% for troponin T and 3% for troponin I in the cytoplasm. And these are the areas we need to catch. Now, before the cell dies, because that cell is not dead. It makes microblips, but it's not dead. If you give it oxygen, it will survive again. It will revive. Now, the decreased myocardial perfusion, like coronary spasm, coronary embolism, coronary dissection, hypotension or shock, severe respiratory failure, or severe and anemia, all cause decreased myocardial perfusion. And increased oxygen demand, we get sustained tachycardia, severe hypertension with or without left ventricular hypertrophy. What about other situations without signs and symptoms of acute ischemia? This typical chest pain that people see. Now we have acute myocardial injury. We call that acute myocardial injury in heart failure, myocarditis, cardiomyopathy, coronary vascularization, PCI, cardiac surgery, catheter ablation, defibrillation, shocks, and cardiac contusion. What about systemic conditions? We call it coronary myocardial injury, chronic here. Here we call it acute. So when do we have chronic myocardial injury? People call that even chronic coronary syndrome. We get sepsis, infectious diseases, chronic kidney disease, pulmonary embolism, infiltrative diseases like amyloidosis, sarcoidosis, toxic agents like chemotherapy, critically ill patient, strenuous exercise, and rhabdomyolysis. These are all the situations and differential diagnoses of patients with chest pain that can present in the to the emergency room, and they might have an increase in troponin in their circulation. So the fourth universal definition of myocardial infarction recommendation for utilization of biomarkers states as follows: myocardial injury to be used when there is evidence of increased cardiac troponin with at least one value above 99 percentile, 6 specific for male and female. Greater attention should be placed on recognition of type 2 MI that I showed you, which is the oxygen demand and supply imbalance, unrelated to the acute coronary thrombosis. Cardiac troponin I and cardiac troponin T remain standard biomarkers for ruling in or ruling out myocardial infarction and myocardial injury based on assay-dependent algorithms. Analytical sensitivity provided by high-sensitivity cardiac troponin assays is critical for early rule out and assists in defining assay-dependent delta that really helps us a lot in making diagnosis. Definition of high-sensitivity cardiac troponin assays is based on the imprecision, 10% CV at 6 specific upper limit and upper reference limit, and ability to measure normal subjects above the limit of detection in more than 50% measurement in both males and females separately, not combined, 50% of males and 50% of females, which supports the IFCC CCP, which is the Committee of Clinical Application of Cardiac Biomarkers, as well as the AACC, which is the American Association for Clinical Chemistry Guidelines. Now, contemporary and point-of-care assays are generally analytical and clinically inferior to the assays so far for diagnostic use, and are unable to define biological variation, and the point-of-care was tackled by Dr. Salam Saadeddin. Now, troponin release after myocardial injury. We have three formats: either a big rise, the one that Dr. Saadeddin showed you, peak reached, and then they start to come down below the limit of detection, or it doesn't peak too much, it peaks only a little and goes down below that. That's called minor myocardial injury, and we talked about the causes that can give us this. Or it will wax and wane around the detection, the 99 percentile, small values, sometimes down, sometimes up chronically, without peak and coming down in the situation. This chest pain in the emergency department is extremely important, because about 20 million patients each year present with symptoms suggestive of myocardial infarction to the emergency rooms in North America and Europe. 20 million patients. Now, range of diagnosis across the high sensitivity coronary cardiac troponin concentrations. If we look at the concentrations here, for example, troponin right, from 5 nanogram per liter to 50,000 nanogram per liter, which diagnosis can fit where? This figure helps a lot. Usually healthy individual lie around this, which is the 5 nanogram per liter or less, and that gives us a negative predictive accurate value of for MI for 99%. Now, when it comes above in the 8, around the 10, then we get stable angina, heart failure, LVH, subclinical heart disease. Ruling out MI in this situation with 95% negative predictive value. If it is below, if the value is below the 99 percentile, if it's a little above the 99 percentile, then it can include lots of things. MI, stress cardiomyopathy, chronic heart failure, pulmonary embolism, chronic kidney disease, shock, hypertensive crisis, subendocardial damage, etc. But as the values increase from low to moderate to high to very high, in the very, very high, when we reach thousands for the cardiac troponins, it's mainly large MI and myocarditis. If it is less, in 1,000 to 10,000, it is large MI myocarditis, but also cardiomyopathy and critical illness. And between 100 to 1,000, it includes all what the above with subarachnoid hemorrhage and acute heart failure, etc., etc. So that gives us an idea where to look when we have the level of the troponin. Now, acute coronary syndrome, 1.57 million hospital admissions of acute coronary syndrome, 1.24 million unstable angina and STEMI, and 0.33 million in the United States with STEMI, which is high volume. And when what do we get here? 1 year mortality is high for both, 11.6 for the non-STEMI, and it is 9% for the STEMI. So it's very high volume, very high risk. Mind you, patients presenting with chest pain, around 2.1 million out of these are sent home as non-cardiac cases. 25,000 of those sent home develop usually myocardial infarction, so it's very high liability. So it's high volume of patients, very high risk for the patients, and high liability for the doctors. So the topic is very, very important. That's why it affects both the patient as well as the treating team. Here, if you see the non-MI presentation of chest pain represent almost 66% of those come to the emergency room with chest pain. So the delta that we talked about, the rise and falling troponin levels, the delta change, differentiate acute from chronic cardiomyocyte damage. The more pronounced the change, the higher the likelihood of acute myocardial infarction. That's why the European Society of Cardiology in 2015 proposed the 0-hour to 1-hour rule in, rule out algorithm. Very important algorithm that was proposed by the European Society of Cardiology, and they gave numbers for troponin T, Lexus, troponin I, Architect, and high sensitivity. Of course, all of them troponin I here, the dimension best. Mind you, this algorithm to be implemented, to be able to use it, it's applicable for chest pain patient with onset of chest pain of more than 3 hours duration. If it is less, it cannot be implemented. So if we take the numbers that they give back to the very, very nice, beautiful figure that Dr. Saadeddin illustrated and showed us the utilization of cardiac troponin T and I, we see here cardiac troponin T. What happened in the situation that the European Society of Cardiology proposed these numbers, 5, 12, and 52 for troponin T. If you get a reading here, less than 5 nanogram per liter, rule out myocardial infarction. Negative predictive value is 99.1%. And it's not only, it's for females, males, elderly more than 62, less than 62, with coronary disease, without coronary disease, with the inset less than hours, 2 hours, the GFR less than 60 or more than 60, kidney disease or no kidney disease. So the total negative predictive value is 99.1%. So if the first reading is between 5 and 12, 5 and 12, we have to get another reading after 1 hour. If this reading is less than 3 nanogram per liter rise, less than 3 nanogram rise, it's unlikely to be myocardial infarction. If it's more than 5 nanogram rise, yes, it is myocardial infarction. If it's between 3 and 4, we observe the patient. If the first reading between 12 and 52, we get and the second reading at 1 hour, which that's why we call it 0 hour here, and here after 1 hour, and we get another reading. Less than 5 nanogram rise, observe. More than 5 nanogram, it's myocardial infarction and admit, it's rule in. Any reading above 52, it rules in myocardial infarction in this 0 to 1 hour rule in, rule out algorithm. Again, for the architect troponin I, they gave this number 2, 5, and 15. And it is exactly the same. We can rule in and out, repeating the same scenario that we mentioned for troponin T. But the difference here is 6 nanograms, not 5 nanograms as for troponin T. And here it is the same, more than 52. Notice when we go high in the level of troponins, nothing makes a difference because it is really myocardial infarction no matter what you use, troponin IT or whatever assay of troponin I. So recommendations by the European Society of Cardiology 2015 states it is recommended to measure cardiac troponin with sensitive or high sensitivity assays and obtain the result within 60 minutes, class 1A. Rapid rule out protocol 0 to 3 hours that Dr. Saadeddin mentioned also still exists as class 1 in the 2015. The rapid rule out rule in 0 to 1 hour protocol I just told you is very highly recommended by the European Society of Cardiology. If you observe the patient and no values, you can repeat it in 3 to 6 times, also class 1. Now the 2020 European Society of Cardiology guidelines just came out a few months ago at the end of last year. What did they say in the situation? Because in the last few years, multiple studies using high sensitivity cardiac troponin T and I with thousands of patients confirmed the validity of this algorithm. Now, if we look here between troponin T and 1 hour, using the 0 to 1 hour algorithm, more than 4,300 patients examined here or tested or studied. For troponin I, 3,500 patients studied. And what did they find? They found out that rule out by this in cardiac troponin T, 57% of the patients, negative predictive value 99.8%. Positive predictive value 74.5% for troponin T. Now for troponin I, also negative predictive value 99.7%, almost the same. So both work in this situation, mainly for the rule out of the acute coronary syndrome when they present to the hospital. So the highlighted recommendation in the 2020 European Society of Cardiology guidelines is the 0 to 1 hour algorithm. They made it, they call it as a first choice to use. And then they introduced, after 3 hours, if you observe the patient, after the second reading in 1 hour later, 3 hours later, you can repeat it to group in or out, also class 1. New key recommendations that were introduced strongly, an alternative to the 0-1 hour algorithm, 0 hour to 1 hour, they introduced something called 0 hour 2 hours if this algorithm is tested and available in the center that's testing the patients. Another new key recommendation in 2020 European Society of Cardiology guidelines is for diagnostic purposes. It's not recommended, class 3, not recommended to routinely measure additional biomarkers such as CK or CKMB or HFAB or copeptine or other marks. That's class 3. So troponins are really the kings of the recognition of myocardial injury and infarct. Major changes in the recommendation. You remember I told you that the 2015 put the 0 to 3 hours, 0 hour to 3 hours as class 1, but the 2020 made that less important. They called it class 2A, might benefit the patient. And because they focused on the 0 hour to 1 hour to be the first choice in the situation. Not only that, they also added to that whether to when discharge, to the additional testing, what to do. the stress testing, the CT angio, or angio per se, or admit immediately for angio, do echocardiography, etc., etc. Very helpful. You remember from the first slide I showed you before, in the 2015 guidelines, they gave these numbers to implement in the algorithm. But now we are in 2020, 20 when they came out with their specification or the guidelines, and there were more machinery, more assays that came out in the literature. That's why they proposed numbers for very low, number one, the change at 1 hour, change after 1 hour, if it's high or low, etc., etc. For these patients to be used in the algorithm for 0 hour to 1 hour algorithm. But not only that, they also introduced the 0 hour, 2 hours numbers to use in the algorithm when you implement it. Mind you, look here, to be detected, blah, 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 and not all of them were studied in large randomized controlled trials, so values are not consistent with the larger evidence-based literature, are not referenced even by the European Society of Cardiology 2020 guidelines. So we interpret these numbers here exactly with caution. So finally, therefore, high sensitivity troponin established itself in the guidelines as the useful tool for rule out or rule in myocardial infarction. So the detectable cardiac troponin is associated, now this is for the MI and for the acute coronary syndrome. What about other use of cardiac troponin as a risk for death and adverse cardiovascular outcomes? More than 19,000 patients with chest pain without MI, mind you, without MI, they found those who had detectable cardiac troponin T in them, they followed them and they found out what happened to them. They looked at the level, if it's less than 5, up to more than 50. What happened? All-cause mortality, this is the reference. If it is 5 to 9 only, doubled. And if it is far more than 50, it's more than 9.6 times. For cardiovascular mortality, 27 times more than the reference if it's normal. And MI, the higher the level, the higher the chance of MI reaching 2.77 in level more than 50 if the patient was having that. Heart failure, 13 times the reference to develop heart failure in those patients who came without MI, but they were found to have cardiac troponin. What about the mechanism of detectable troponin in heart failure? Now, heart failure. If we look at heart failure, ischemia-induced microblips that I showed you, direct toxic myocyte necrosis, myocyte apoptosis, as well as leakage from cytosolic cardiac troponin pool, and they can have acute coronary syndrome. So all of these can lead to elevated troponins, and the rise and fall still exist, but only in chronic heart failure. If somebody comes with acute heart failure, you cannot implement the rise and fall 0 to 1 hour or 0 to 2 hours algorithm or any algorithm for acute heart failure. It's only for chronic heart failure. So what did they see? How can we look at that? We look at these levels here, the lower detection limit, the 99th percentile, and the MI level. Patients with chronic heart failure, 92% have this value. And 31%, they have 14 to 100, and 0% have more than 100, which is the MI level of the chronic heart failure. They are usually in the low one, waxing and waning between 3 and 14 below the upper limit of upper detected limit, upper reference limit. What about acute? Acute, usually 100% of them have this, and 75% between 14 to 100 and 62% can have it above even 100 nanogram per liter. So the higher baseline cardiac troponin levels in patients with heart failure consistently being associated with higher rates of overall mortality, worsening heart failure, new or recurrent MI, or cardiac transplantation. For overall mortality and worsening heart, these apply to both patients with acute and chronic heart failure, similar for troponin T and troponin I. The higher concentrations are associated with worse outcomes for new or recurrent MIs and for patients with cardiac transplantation. Now, a study showed in apparently healthy donors, we're talking about apparently healthy donors, during a median of 5.2-year follow-up, what did they find? They found out that in these healthy donors, those who had higher troponin T, they ended up developing cardiovascular disease and heart failure. But not MI, believe it or not. Heart failure. Now, why these patients with cardiac troponin, higher troponin level in circulation develop heart failure? This brought really the question, because it leads to a future risk of developing heart failure. This question is cardiac troponin a risk marker or a risk factor for heart failure? I went over all these causes of myocardial damage that will lead to release of troponin in blood. Now, it's postulated that this troponin is attacked by the immune system, and antibodies are formed for that, mainly for cardiac troponin I, which is larger molecule. And then it attacks these cardiac troponin I antibodies attack the cardiomyocyte. Autoimmune reactions take place chronically, and the patient ends up having heart failure. Very intriguing theory, and research is really following that to see if that's true or not. What about now high sensitivity troponins and renal dysfunction patients? Baseline concentration of cardiac troponin are often chronically elevated in patients with renal dysfunction, even in conditions other than acute MI, and are associated with poor diagnosis. Pathophysiology of chronic cardiac troponin release may be caused by some forms of cardiorenal syndrome triggered by inflammatory process leading to chronic myocardial injury. High sensitivity cardiac troponin assay maintain high diagnostic accuracy in patients with renal dysfunction, and high sensitivity cardiac troponins are negatively correlated with the GFR, glomerular filtration rate. The lower the GFR, the higher the high sensitivity cardiac troponin concentration. Now, high diagnostic accuracy can be maintained using higher levels than the 99th percentile, mainly more than 29.5 nanograms for cardiac troponin T. This for high diagnostic accuracy. Kidney disease guideline, the guidelines for kidney disease recommend using T, cardiac troponin T, not I, to monitor dialysis patients for chronic disease. High sensitivity cardiac troponin T and not high sensitivity cardiac troponin I achieve a sensitivity of 99 percentile of negative predictive value and more than 99 percentile, 9.5 for MI, with a cutoff of less than 6 nanogram and a GFR more than 90. If the GFR more than 90 and the level of troponin T less than 6, the negative predictive value is more than 99.5% with a sensitivity of 99. Now, what about COVID era that we are going through? High sensitivity troponins with COVID-19. Retrospective single-center study for 126 patients reported early this year, just a couple of months ago, showed that they used Abbott Architect high sensitivity cardiac troponin I, 6 specific 99 percentile. I know that Dr. Saadeddin showed you what does that mean. At baseline, if they come with higher than the 99 percentile at baseline to the emergency room, it is significant predictor for mortality in COVID-19 patients. Look here, those who had the low value, value above the 99 percentile, mortality was 5.3. Those were above the 99 percentile, mortality was 40%, 8 times more, with a predictive value of less than 0.001. And when the value of troponin was less than 5 nanogram per liter, it identified patients at low risk with COVID in COVID patients. Another study using high sensitivity cardiac troponin T, the Cobas Roche, if it was 50% of those admitted with COVID-19 had more than 99 percentile upper reference limit. And those patients who had this high, they went to the intensive care. 37% of them went to the intensive care unit, while only 5% of those who did not have it, and there was statistical significant value. On the other hand, those observed and discharged from the emergency room, 40% of them had very low cardiac troponin versus those who had high. Only 7% of those had high value went home, while the 43 of those with very low went home. So the higher the level, the worse the prognosis. Now, emerging indication of high sensitivity cardiac troponin patients undergoing non-cardiac surgery. The recent study fully support the recommendation for systemic screening using high sensitivity troponin measurement once before surgery and once daily in the first 2 postoperative days. But for whom? In high-risk patients such as those older patients more than 65 years old or younger, older than 45 and less than 65, but with documented coronary, cerebral, peripheral artery, or a disease if undergoing major non-cardiac surgery to diagnose or to pick up post-operative or peri-operative myocardial infarction. The clinical implication, so in summary, which goes with the representative cardiology 2020 recommendation, compared with standard cardiac troponin assay, high sensitivity assays have higher negative predictive value for acute myocardial infarction, reaching 99.8 or whatever, 20.8. Reduce the troponin blind interval leading to earlier detection of acute myocardial infarction, result in 4% absolute and 20% relative increase in the detection of type 1 myocardial infarction and a corresponding decrease in diagnosis of unstable angina, are associated with 2-fold increase in the detection of type 2 myocardial infarction with all its causes. Level of high sensitivity troponin should be interpreted as a quantitative marker of myocyte damage. This is another use for it. It's a quantitative marker for myocyte damage. The higher the level, the greater the likelihood of MI. Elevation beyond 5 folds of the upper reference limit have more than 90% positive predictive value for acute type 1 MI. Elevation up to 3-fold the upper reference limit have only limited 50 to 60% positive predictive value for acute myocardial infarction, may be associated with broad spectrum of conditions, as I showed you. It's common to detect circulating levels of cardiac troponin in healthy individuals. So if you pick it up, it's common that people might have it. Lastly, rising and falling cardiac troponin levels differentiate acute, as in acute coronary syndrome, versus from chronic cardiomyocyte damage. The more pronounced the change, the higher the likelihood of acute MI. Keeping in mind that, remember, for everybody, early diagnosis of myocardial infarction is the most important indication for high sensitivity cardiac troponin assay, and high sensitivity cardiac troponin assays complement, do not replace, they complement detailed clinical assessment, including chest pain characteristics and the electrocardiogram. So they do not replace them, they only complement them, mainly highly used in the rule out of the myocardial infarction. Thank you very much for your attention.
Thank you very much, Dr. Habab. It really was great. As we anticipated, you really cover a wide spectrum of the conditions that is we see in our daily practice. You told us really a very nice algorithmically how we can deal with these different situations. And I hope that should really, such sessions should really improve our utilization and make it more cost effectiveness, inshallah. Just before we take in the question, I'd like to again to indicate to the audience that is the CME hour. You don't need to do anything. A survey will come to your email. You just need to answer that survey and put your Saudi Council number, and then the 2 hours will be generated to your account. because we had a lot of questions about this. Now, let us start with the first question, Dr. Salam. The question, why the troponin rise or the troponin is different between male and female, and why it is different between different ages?
They found out that there is a difference in the troponin between males and females. It is because of the muscle mass of the males and females. And that's why for different ages, for older people, also it is the difference of the muscle mass for the elder people.
Okay, great. A question here to Dr. Muhammad. They're asking here, now this different troponin rise and fall, does it give us an idea about the cardiac event? So the timing of cardiac event, I think he means.
Of course, you see, yeah, we have a rise and a fall. I mentioned two types of rise and fall. The chronic disease, or they call it chronic coronary syndrome usually. The rise and fall is around the line, the limit of detection, the 99th percentile. But when we have rise and fall, we have it in two situations, as I showed you. Either with a peak, big peak, that's the acute coronary syndrome mainly, or massive acute myocarditis, or the little rise and then the fall, which is the type 2 that we talked about of myocardial infarction. So the shape of the rise and fall definitely helps us. And I showed you that arrow, if you follow that arrow that I showed in one of the slides, it showed that you can, at lower level, you go with the type 2 universal definition of myocardial infarction, the oxygen supply and demand, while if you go at the other end, you get the acute coronary syndrome, which is the myocardial infarction. Our interest is in the early one, where we can pick them up early, differentiate between is a early stage of acute coronary syndrome, as well as the oxygen demand and supply difference with type 1 and type 2, to manage them properly, either catch the patient so early in the myocardial infarction. Because if we find troponin in the thousands, what are we going to do? The muscle is necrosed already, the patient had it, and we did not save any muscle. Time is muscle in myocardial infarction. That's why we want to pick it up so early or rule it out early. If we rule it out early, we save money. I showed you that almost 66% of those who come with chest pain to the ARE, they come with chest pain. But not all of them have myocardial infarction. If we admit them all to a CCUs, or then there's a big burden, cost very high. So that's the area where the shape of whatever rise and fall that we talked about come handy.
Another question for Dr. Muhammad is asking, is there a difference in management between type 1 MI and type 2 MI?
Absolutely, absolutely. Now, if type 1 MI, as we said, it is mediated by what? It is an early stage of thrombotic process going, atherothrombotic going within the coronaries. So we go with the acute coronary syndrome management, aspirin, the nitridil, the heparin, and then finally the coronary angio, while the other one is oxygen demand and supply. Tachycardias, we treat them. Hypertensive emergencies, we treat them. We correct them, etc., depending on the cause, which is totally different from the pathophysiology of atherothrombosis in type 1 myocardial infarction.
Great. Dr. Salam, he's asking, so repeating the troponin I every 3 hours in patients that has increase in troponin I less than 0.05.
It depends on which troponin I they are measuring, because I don't know what is their assay. So the value here, I don't know what does it mean here, the 0.05. But as I showed from the slide that showed, if it is above the upper reference limit, yes, he has to do another reading after 3 hours.
Great. Now, the lab has to do calibration for the high sensitive troponin?
Yeah, what do you mean?
By calibration, like establishing the level, like is it the same level of troponin I in National Guard? Is it the same in the military hospital, or is different from hospital?
I mean standardization of the assays.
Correct.
Usually, if you are doing Triponin T, it is standardized because it is mainly in Roche company. So the value in any hospital will be the same values. We use the same values. But for Troponin I, if you are using different machines, it is very difficult to standardize because each method is measuring different epitopes, and this is a big issue for standardization of cardiac Troponin I, which is now the IFCC is studying, and they are trying to standardize it to give almost the same values. But for cardiac Troponin T, it is the same. Okay. So you have to know exactly your values in your hospital, and Great. It is difficult to compare it to others, except if they have the same machines.
Okay,
now the same machines, it will be the same.
I see. Now, as a question for both of you, what about the role of myoglobin now in diagnosing?
Now, myoglobin is the used to be الطفل المدلل, the kid. The earliest rise and the earliest fall of myoglobin. The problem with myoglobin, it is non-specific. It comes from the skeletal muscles. If you stick the patient with a needle, his myoglobin is going to go sky high. You cannot differentiate whether he's having myocardial infarction or not. The non-specificity of myoglobin killed it. That's why it's really, nobody does it for screening. It's not in any guidelines.
And also because of high sensitivity troponin assays now, you can early detect, so it's fine.
Because even CKMB, as I showed you, is kicked out of the game. Now, with the 2020 guidelines, even CKMB, which everybody used to do, now it's class 3. What about myoglobin, which was kicked out in the 90s?
Okay. Now, another question is about the role of markers in general post cardiac surgery.
Yes, and if you remember the universal classification of myocardial infarction, this comes under category 4. Myocardial surgery and troponins spill after it. Yes, there are troponins spilled after myocardial surgery, depending on what type of pump on pump, blah blah blah, etc. But you use it usually, and the studies, we initiated them, believe it or not, very early in the late 90s, that troponin measurement post-cardiac surgery, if it goes beyond, even CKMB was used at that time, more than 3 to 5 times the normal, it indicates intraoperative damage more than expected for that surgery. So yes, they can be prognostic if they are really released in sky high, or they can reflect a myocardial infarction. How do you reflect it? If we have high suspicion of a patient with very bad coronaries, for example, who went for 4 or 5 grafts, then we will see that when he came out, he was fine. His ECG starts to have some changes. You will have another peak. They will peak after cardiac surgery, but you will have another peak. It will be double hump in the curve. If there is another peak, then there is a fresh injury post-cardiac surgery. Yes, you can do it if you suspect that there is a graft closure or whatever.
Okay. Dr. Salam is asking, do troponin assays affected by a drug interference?
You need to really know your assay. You have to check your insert sheet. They mention usually the limitations for your assay and whether it is affected by drugs, and they list the drugs interference, if any. So you read assays, and mainly heparin, it might affect. So this is why it's the recommendation usually to use the serum instead of the heparinized plasma.
Okay.
But you need really to see also your assay whether it is affected or not. You have to check your assay, your insert sheet.
Okay. Now another question is about of having a myocardial injury a few days post myocardial infarction. As we know, troponin stays in the circulation. And then if the patient coming after a few days, how will you differentiate?
Yeah, you mean patient had MI already and he's coming after a few days?
Correct.
After a few days, you see, usually they fall down. The definition, when they came out with the definition of myocardial infarction, they said it's a 20% rise or fall above the 52 limit that we were talking about. If you are in the downgoing or upgoing before you reach the peak. If you are upgoing, there will be a rise. The rise should be more than 20%. That's the conventional we're talking about now. Because I said the high sensitivity usually at the low level, not at the high level. But if they come after 2-3 days, you will find, if you get a measurement, you will find that, for example, 120, then you get at the second reading, it will be down. It will be 80, 85. So it will be going down. Mind you, that as the Dr. Saaduddin showed you, in that kinetic curve, there will be days over days. Cardiac troponin finishes at 7 days. Cardiac troponin T finishes at 10 to 14 days. Now, these days, the limb of the kinetic is going down, so it will be a fall. More than 20% fall reflects a previous myocardial infarction. Mind you, you will have the ECG changes, the echo will show you that he already infarcted, the pain is gone, and he is developing coughing from the failure after MI, etc., etc. That's why troponins complement clinical, which is the symptoms, the pain mainly, and the ECG findings. They do not replace them.
Thank you very much for elaborating on this point. So it's really the clinical setting is a very important thing that is unfortunately we forget. And it's very important always to take the patient risk profile as well.
Absolutely.
Another question, what are the effects of hemodialysis in end-stage renal disease on cardiac?
Troponin. Yes. I mentioned to you because the kidney guidelines, the kidney management guidelines advise for T rather than for I, because apparently I is affected and removed by dialysis. So patients on dialysis, if you want to make a diagnosis for them, use troponin T rather than I.
But are they washable with hemodialysis?
Absolutely, because they are large molecules. They are larger molecules. The pictures Dr. Saaduddin showed that poor, thinny, skinny troponin T has one area, 5 epitopes that you can attack. It's only one company that does that. While now I think a new company this year or last year just picked up another site. While the other ones it's a huge molecule, it's filterable, and it's affected a lot by dialysis.
Great. Dr. Salam, do you like to add anything about this point?
No, he elaborated right.
Okay, good. He's asking how troponin assay is important as ECG checking and giving emergency drug. Thank you.
As ECG?
Yes, he's asking.
You want to replace troponin with ECG? No way, I'm an electrophysiologist. Although we have the lab people with us, Dr. Saaduddin, the biochemist, but never. ECG is the king. It stays there to start with, but ECG has the false positive or false negative. Early stages of myocardial infarction, the ECG will not be affected unless you get transmural infarct or subendocardial or massive stuff. So you need something that can pick up the changes in the myocardium due to ischemia before the ECG is affected. Mind you, we do the ECG on the skin, we get all the stuff from the epicardial heart to the endocardium. While troponin, they are very sensitive to pick up changes before even ECG changes take place.
So both of them, they should be really.
So both complement themselves, each other.
Okay, but one of the things of the advantage of the ECG that is you can get it immediately.
Of course.
You need to send it to the lab, wait for the lab for the result, and this is why we rely heavily on the ECG in particular, because the question was from the ER nurse or doctor, and I think it's very important to stress the importance of the ECG, that is you can immediately do it in a few minutes.
Of course, when the patient hits the A&E with chest pain, like he's hooked to the monitor, oxygen is given while the ECG is being done immediately. And the nurse will be drawing the blood, sending it to the lab to do the troponins. And now the problem, if we have a point of care troponin, which succeeded to do it at bedside, now they are evolving. There are studies that showing some close sensitivities and specificity, but they are non-practical yet, according to the 2021, the last 2 months report by clinical chemistry. If we have that, that will be helpful. But ECG should be done before anything, when the patient hits the A&E, while the patient blood is taken to be sent to the lab.
But as you said that sometimes if the patient comes too early, cardiac troponin will be really helpful.
Of course, ECG will be normal.
Sure, because the ECG will be normal. But it's just because one of the always having a problem with the STEMI, which is the ST elevation myocardial infarction, and delaying the therapy, that is the ECG is not done immediately when the patient reaches the ER. And I think
now a very important point, if I get the patient and I do ECG and he has ST elevation, I don't want troponin.
Great.
I take him immediately to the lab. I give him TPA or manage him as an MI immediately. I don't need to wait for anything in the situation. There's no indication to do cardiac troponin with STEMI. I want everybody to understand that, except for one indication, which is for prognosis. The higher the level of troponin reflects more damage in the heart, predict more 30 days mortality, heart failure development, etc., etc. While for diagnostic purposes, for STEMI, no troponin. I don't need it. ECG it's called the STEMI, ST elevation MI. So I do it. That's it. Do it troponin for prognosis, for whatever. Yes, but not for management of STEMI. For non-STEMI, absolutely, they are the kings. Troponins to differentiate between unstable angina or non-STEMI, etc., etc. It makes a lot of difference. But for STEMI,
thank you very much. I think this is very important, and I think this is one of the important message actually from the session of today. Is really the clinical pictures is the most important thing.
Absolutely.
Yeah. Actually, one of the thing here, a comment, like some of the hospital, they don't have troponin yet, and they're still using the CKMB.
أقول لهم الرمد ولا العبها يعني what can you do? but I think all assays are becoming cheaper. At least they can get a point of care or whatever if they are remote area or not a large hospital. I'm sure all large hospitals or labs they have it, but if it's a remote small center or whatever, they can get at least a point of care or whatever.
But mostly the conventional.
Yes. Yeah, they will not get the high sensitivity, of course.
Yeah, I think it's very important now. This CK and CKMB is really should not be utilized at all. And I hope really with this session of education, people who have the decision ensure these assays will be available, and because that will really improve the prognosis, improve the diagnosis, and really the time is muscle. So whenever we delay diagnosis, then that is really whatever intervention we'll do will leave the patient with residual damage. And the whole idea of having such session and so is really try to save the myocardial damage, because it's really unfortunately irreversible if we not catch it in the proper time.
Yeah, absolutely. And if you remember a slide I showed you, that it's not only that, but money. People get lots of tests in addition to troponins and the diagnosis and management of acute MI or acute coronary syndrome, and it's a waste of money. In New Zealand, when they stopped CKMB, which was almost, I think, 8 years ago from their labs, they saved millions because these tests were useless. They were done because the doctor is used to write CKMB. And some hospitals have them written in a checklist. They are checked. Any patient with chest pain, do this, troponin, CKMB, blah, blah. for nothing. Nobody looks at them. And they saved millions. So I would advise all hospitals to go by the guidelines of the new 2020, which we implemented in our center, for example, by the way, more than 7 years ago or 8 years ago. That eliminated, you save lots of money and you buy new machines.
Great. I think you really cover most of the important question. I have a lot of compliment for both of you.
Thank you.
The session was really, as I said, visible, clear, efficient, beneficial, and the answer, your answer was very practical. Really, I'd like to thank the Saudi Biochemistry group. I'd like to thank Snibe company for their sponsoring this activity. I'd like to thank the 2,500 audience who
stayed until now.
Exactly, and he made.
And I will tell these people, sorry to interrupt you, that the lectures will be at the site of the Saudi Society of Clinical Chemistry, so they can learn from them more and more.
So I think this is again a very advantage of this session. So please go for it for the people who did miss the first part or the second part, or people who could not really join for a technical issue. So please go to the site of the الجمعية السعودية للكيمياء السريرية and you'll find the recording for this lecture. Again, thank you for everybody who contributed to this, and we see you inshallah another scientific session. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam. Thank you very much. Thank you.
Thank you.
Thank you.